Hello guys, I am Biswanath and welcome to this session on HIV/AIDS. And in today's session, we are going to discuss HIV in great detail. So I will cover all the aspects of HIV, starting from the microbiology to pharmacology and even to the medicine itself. Right. So we'll cover all the aspects of HIV, not all, just you can say most of the aspects, which you get questions in your PG entrances and your prof exams. Right. Okay. If I'm clear, audible, visible, and this note is being displayed, let's start. So human immunodeficiency virus. So it is a RNA virus, belongs to the retroviridae family. So basically, this retroviridae family is divided into two families, right? One is the oncoviridae, one is the lentiviridae. So oncoviridae family, we have HTLV1, HTLV2. HTLV1 is basically causing adult T cell lymphoma or leukemia, and HTLV2 basically causes tropical spastic paraparesis, which is a form of paralysis, right? And you know that this 8th day just was a day back. So December 1 is celebrated as World AIDS Day for awareness regarding this disease. And this is not a disease, just many emotions are connected with it, many social stigmas are connected with this disease. And we as a doctors have the role of removing the fear out of this disease and given good emotional support to the patients who are bearing this deadly infection. Right? So basically, AIDS is not a disease. AIDS is basically compromising your immunity, right? And whenever your immunity is compromised, many pathogens are just rushing into your body and telling that you don't have immunity will cause infections, right? So you'll have many manifestations. We can have pneumocystis cerevisiae infections, respiratory infections, the Kaposi sarcoma and all, right? We have many infections. We'll discuss about that also, opportunistic infections, right? Okay. So I told you retroviridae families have two divisions, oncoviridae and lentiviridae, right? And this lentiviridae is divided into HIV1 and HIV2. So HIV1 and 2 are basically coming under this. And this HIV1 was prevalent worldwide from the very end, from the very beginning, sorry. And this HIV2 is was first discovered in the West African region and the Sub-Saharan region, and afterwards it began to be like distributed worldwide, right? Okay, so we know this from our early classes that HIV is a retrovirus, and it has a enzyme called reverse transcriptase, and this reverse transcriptase is basically converting the viral DNA, the viral RNA, into the viral DNA, and this viral DNA has sticky ends. Sticky ends means it has the base pairs are not primarily present, right? So the DNA is basically sticking to the host cell DNA. And what enzyme helps in sticking? Integrase. So integrase is present inside the HIV. So when we look at the structure of the HIV virus, we'll see that we have three enzymes. One is the protease, one is the integrase, and one is the reverse transcriptase, right? Three enzymes. And we have a diploid genome. This virus has a diploid genome. We'll look at this as we move ahead. So I was talking about the structure. So you can see we have some spike proteins in the envelope. We have the envelope, right, the purple thing, and the spike proteins are just embedded here. So we have GP41 and GP120. So basically, what is happening is that we have something called as a GP160, right? And this GP160 divides into GP120 and GP41. Okay, don't add this, right? So it is not a arithmetic sum, right? Okay, and the gene which is helping in it is ENV gene, ENV gene. Okay, we'll look at the ENV gene in a few minutes. So we have some inner membrane proteins also like P17. Okay, P17 is the outer matrix protein and P24 is the outer capsid protein. Right. So the outer capsid protein is P24 and the protein that is forming the in the matrix area, right? So the outer matrix protein P17, right? And GP41, remember GP41, whenever the HIV virus comes to the host cell, it is attaching to the host cell, right? The envelope is attaching to the host cell. So GP41 is helping it to attach to the host cell, right? and GP120 is helping it attach to the CD4 receptor. Okay. So whenever it is attaching to the CD4 receptor, we have something called as a co-receptor as well. Co-receptor. Co-receptor means we have a second interaction, which is basically sending another signal. Okay. If you don't understand at this stage, just wait for a few minutes. Okay. So I told you we have a set of ssRNA. ssRNA means two single-stranded RNA. So we have a diploid genome and these are positive sense, right? Positive sense ssRNA, which are two in number. This is the genetic material of HIV virus, right? And the size of the virus is 100 to 120 nanometers. And three enzymes I told you. One is the reverse transcriptase, integrase, and protease. You can see the three enzymes as well in the structure, right? Let's come to genes. Okay. So basically, when we are talking about genes, we have structural genes and we have non-structural genes, right? So structural genes we have three, non-structural genes we have six in number. So structural genes we have GAG, POL, IN. Okay, just make a mnemonic or so. I don't care, but you have to remember these genes as well, right? So GAG, POL, and ENV. Uh, GAG is basically forming the proteins. Okay, P17, P24. GAG. Pol is basically forming the enzymes. So proteins, enzymes. So Pol enzymes, right? Enzymes. What are the three enzymes? Integrase, protease, reverse transcriptase, as I told you. And N is I was telling a bit earlier, right? That N is basically splitting the GP160 into GP120 and GP41, right? And this GP120 gene is basically used in the subdivision of HIV virus into clades. So we have different clades of virus. These clades are known to infect a particular area of your human body. Like clade B, we don't have to remember all the clades, just important ones are written here. Clade B infects mononuclear cells and are transmitted during anal intercourse. Okay, and it's most common in Northern America. Clade E is affecting female genital tract. So you can remember EF, right? Female genital tract and transmitted during vaginal intercourse. Of course, genital tract is there, right? So B, mononuclear cells. How you can remember? Just write M, mononuclear cells of M. You can just put a stick here and rotate it. B. So clade B is affecting the mononuclear cells. You can remember like this, right? Okay. Now let's come to non-structural genes. So structural genes we told GAG, POL, ENV. Non-structural genes we are now discussing that these are the regulatory genes. So first we have the TAT gene, TAT. Okay, so it is basically uh, TAT gene is basically activating the viral transcription, right? From DNA to RNA, it is basically catalyzing the viral transcription. TAT, TAT. Then we have REV, REV. Okay, TAT, then REV. REV is controlling the passage of viral mRNA from nucleus to the cytoplasm. Right. So mRNA, after it is transcribed, it will move from nucleus, it will move out of the nucleus, right? So REV is basically taking it to the cytoplasm. Understood? Okay. Then we have NEF gene, NEF. So it is basically coding for NEF protein. Okay. And the NEF protein is decreasing the CD4 count and the MHC1 expression on virus infected cells. Why this is important? Because look at this. Whenever we have MHC1, good MHC1 expression and good CD4 expression, our immune system is basically trying to kill the cells, kill the you can say virus very proactively. But what the NEF gene is doing or what the NEF protein is doing, it is basically decreasing the expression. If it is decreasing the expression, our immune, it is basically a mechanism to evade the immune response of the body, right? So it is basically helping to evade the immune response. So it is detrimental to us, right? Good for the virus as well. Okay. Then we have the WIF gene, PIF gene, WIF gene. Okay, and this is the WIF protein. Just I wrote gene here, so it is the WIF protein. Okay, so it is basically inducing a hypermutation in the retroviral DNA. Okay, So it is basically inhibiting the ApoBE3636. Don't have to remember this one. Just that it is increasing the pathogenicity of the virus by inducing hypermutation in retroviral DNA. Understood? So it is basically causing hypermutation. Do you know hypermutation? Whenever the mutation occurs at a very high rate, right? There are many chances of error, and when there are many chances of error, okay, then opportunistic infections will come to flow, right? So it is basically causing hypermutation. Look, it is causing a variants of this virus, okay, which are not desirable for us. Then we have the VPR gene, which is coding for the VPR protein. Okay, so it is transporting the viral core from from cytoplasm to nucleus of non-dividing cell. Okay, it is transporting the virus, the viral core, the core of the virus, because the nucleocapsid is left behind from cytoplasm to the nucleus. Okay, of the non-dividing cells. Then we have the BPU gene. BPU gene is basically enhancing gene, which is catalyzing the release of the daughter virions. The release of the daughter virions, right? So what we learned, we have just so we have TAT, the REV, NEF, VIF, VPR, VPU. This six, right? So okay. So how to remember? Okay. So first, you can remember you must have been in a train, right? So train TRN. I'm writing TRN for train. Train BBB. Okay, just an absent mnemonic, but it may help you to remember. So I am telling it. But if you can make a better mnemonic, then do make it. I don't have any problem, but you have to remember. Just that's the issue. TRN BBB. Okay, you must have heard AEIOU. So AEIOU, but here we'll not write AEIOU. In the place, we'll write PP. Just a minute. AE. Okay, you just write AEEIOU. AEEIOU. You can just cross it. You can just cross this right here. PP. Okay. Now you can guess the other letters. So we have TAT. You have REP, NEF. Okay. BIP, BPF, PPU. Right. So this is a REP. Sorry. Okay. You can remember this, right? I hope. Yeah. Do whatever. Just you have to remember this. And from the names itself, you can guess the roles, right? It's not a very big issue. Okay. So viral DNA in the presence of reverse transcriptase is basically changing into a DNA, right? And okay, another important point is that BPU is absent in HIV-2 virus. So HIV-2 virus doesn't have BPU. In the place, it has BPX. Okay, last gene, the BPU gene is replaced by BPX. Okay. So reverse transcriptase is basically forming a RNA DNA hybrid. Means a strand of DNA and the strand of RNA. The strand of RNA was retained. Then it makes a strand of DNA. Then the RT, the reverse transcriptase, has a ribonuclease activity. What is the meaning of ribonuclease activity? It's basically breaking the RNA strand, which is that forming the hybrid. We don't want a hybrid, right? So it will break down the this pink strand. It will break down this pink strand, and this forms a good one. Okay, a DNA one. Okay, we don't require this RNA one, right? So this is a DS proviral DNA, double stranded proviral DNA, and this integrase is basically attaching this DS proviral DNA into the host, right? Okay. We don't require this. Okay. Type specific GP120, GP41. Group specific is P24. Just remember this too. Okay. So what are the receptors? The receptors for HIV is CD4, and this CD4 receptor, I told you that it is present on the TH cells and also on the macrophages. Okay, T helper cells and the macrophages, and these two cells are the primary target of the HIV virus. Understood? So Th1 cells. Uh, this also have a co-receptor present. Okay, if the Th1 cells have CD4 receptor, it will have co-receptor CXCR4. It will have co-receptor CXCR4. And if the monocyte or macrophage has the CD4 receptor, it will have the co-receptor CCR5. Okay, so here we have CXCR5, and if the macrophage or monocyte have this co-receptor, then CCR5. Understood? Okay, so CXCR, this basically co-receptor, what is the function? So we have a receptor, but the second interaction of the virus with the receptor is needed for activation, right? So CXCR is the co-receptor which is present. It is existing along with the receptor. Okay. So it is basically causing lysis of the cell. Okay. And this type of lysis, the CXCR4 is present. We call the we call this type of the HIV virus is the X4 strain viruses. Okay, or lytic strains. It's causing lysis. And CXCR is present on the APCs, so these are not causing lysis. Okay, just remember, whenever the HIV virus infects any cell, be it a T helper cell or a macrophage, it is infecting. It is causing the daughter virus, but it is causing lysis only in the TH cells. It is causing lysis of the TH cells only. It is not causing lysis of the monocyte or the macrophage. Just remember this. Okay. So TH cells, it is causing lysis, and whenever there is a lysis of cell, the cell-mediated immunity will obviously go down, and when it's obviously goes down, then there will be increased opportunistic infections and malignancies, right? Okay. And here, monocyte and macrophage is basically acting as a factory. Even if the products are formed, do you think the factory will be destroyed? No, the factory is going on. It will be normal. It doesn't kill any monophage or macrophage. T helper cells are killed in a high number. Another target is Th17 cells as well, right? So, if you have read the inflammation chapter, you have read the immunity chapters, immunology chapters, then you must have your mind must have striking acute and chronic inflammation, somewhat like that. Just focus on this, okay? And if you haven't read, then well, good. So, another target is Th17 cells. It produces interleukin 17, and interleukin 17 is chemotactic for neutrophils, right? So it is followed by the bloodstream infections by the gut flora, because neutrophils will start to come, and mucosal immunity is involved over here, right? Okay, then infections of monocyte or macrophages in brain, if it occurs in the brain, leads to the formation of multinucleated giant cell, and significant CNS symptoms will occur. It will not kill the cells, but as it is infecting it, it will form multinucleated giant cells. Because when your body tries its level best to fight against these infections, but when it cannot, it tries to club cells together, right? It tries to club cells, and this clubbing of cells leads to the formation of a cell with multiple nuclei, which is called a multinuclear giant cell. Okay, if you have read the formation of a granuloma in pathology, then you must be knowing this concept, right? Okay, so fusion of HIV infected cells in brain and elsewhere because of GP41. Okay, this causes the formation of syncytial cells, and the syncytial cells are attacked by the TC or the cytotoxic T cells and are killed, right? Okay. So HIV is a super antigen. What is super antigen? You know, super antigens are those antigens which cause the polyclonal activation of T cells. Polyclonal activation means many T cells will try to infect. Okay, and ultimately these T cells are gonna suffer, right? Because it's a polyclonally activated ones. Okay, just remember this. If you're This is a thumb rule of HIV. Once infected, always infected. Once you are infected with HIV, you are always infected with HIV, because there is a sustained infection of the lymphoid tissues. Remember, HIV is not a bloodstream infection. HIV, I have wrote somewhere. Yeah, HIV is not a is an infection of lymphoid tissue. It is not a bloodstream infection. Okay, so lymphoid tissues are affected. You aren't infecting a bloodstream. There is no viremia. You can treat viremia easily, right? HIV is not treatable. We have prevention only, no cure. To cure, some drugs are there, but drugs don't cure HIV. Drugs basically are prolonging the life of the patient. It is not causing any kind of, the patient will gonna succumb to HIV. Okay. What are elite controllers? We have a concept of elite controllers, okay, in HIV. So elite controllers is basically a rare group of HIV infected people. Okay, let's assume we have 100 people infected with HIV, out of which one or two. Basically, we say one. Okay, about 1% of those infected are elite controllers. Means they have no detectable HIV in blood. You can detect in serology. The CD4 count will be normal. Okay, it doesn't depend on gender, mode of infection, anything. Don't have HIV in blood, the CD4 count is normal. What is the reason? Because they have some HLA predisposition. HLA, you know, MHC, you know. I suppose you know because it is important. Whenever we have any HLA predisposition, we suffer from variety of symptoms. HLA-DR predisposition, HLA-B27 predisposition. Okay, like this. Some HLA alleles are protective. That's why the person is having no detectable HIV and no very you can say normal, okay, almost normal CD4 counts, right? And inhibition of cyclin dependent kinase known as P21. Okay, inhibition of P21 also causes this. Another group live for many years without an opportunistic infection and decreased CD4 count. When it affects in the NF gene, NEF gene, okay, then some may live for many years without any infection. Okay, so these are some of the special cases you can say. Okay, long-term non-progressors means these are the people which, if you detect, okay, a positive charge protein is present in their blood. So this is called the alpha defensins. So whenever the person produces alpha defensins, it interferes with the binding of HIV to the CXCR4. CXCR4 was the receptor present in the TH cells. Okay, it is a co-receptor. So it alpha defensins interfere with the binding of the HIV to the CXCR4 and blocks the viral entry. Understood? Okay. So okay, this is an important part. HIV can also cause thrombocytopenia. Okay, how? Because it is leading to the polyclonal B cell activation. It is activating a lot of B cells, and these B cells means they are producing immunoglobulins. So immunoglobulins is a gamma globulinemia as well. Okay, and we have thrombocytopenia as well. Understood? Okay. How HIV evades the immune system? How it is evading the immune system? How it is bypassing our immune system and going on to infect us? Okay. So persistent infection is due to the integration of viral DNA into host cell. First of all, it is integrating its own DNA into the host cell. Host cell is thinking that this is mine and let's start producing. So it is basically taking the resources and is dumping you, right? Okay. Just you can relate somewhere else. Okay. Or it is in second one. It is increasing the rate of mutation in ENVG. So ENVG in the envelope, we told right, GAG, Paul, ENV. Okay. So ENVG was producing that changing the GP 116 to 120 and 41. Right. It is increasing the rate of mutation in ENVG. It is causing the production of TAT and NEF proteins. TAT and NEF proteins, which are decreasing the expression of class 1 MHC. Okay, these are decreasing the expression. Decreasing expression means decreasing effectiveness, means it is detrimental for us, good for the virus, and the virus is happily progressing in your body. So that's why use protection. Okay. So let's talk about some of the medicine aspects. Let's talk about the clinical features of HIV infection. So we have three stages basically: a early acute stage, a middle latent stage, a late immunodeficient stage. Right? Early acute, middle latent, late. early acute stage. So it occurs 2 to 4 weeks after infection. So we have some symptoms like you must have heard IMN, infective mononucleosis. IMN like symptoms will occur. A macular rash will be present on trunk, arm, legs, and sparing the palm and soles. This is very important. In medicine postings, they will ask you which rash is not sparing the palms and soles, which rash is sparing the palms and soles, and this type of questions, right? Okay, so this is the primary infection. Afterwards, it shows a period of clinical latency. Okay, so this is the CD4 count in the blue. So this is the primary infection, the primary upbeat, right? Then it is latent for many years. And it's latent. It just it like you must have seen those children. They will hit you in your head and will hide somewhere, right? And will remain latent for many can say. Then afterwards will not pay attention to them. Then they will just stand up and say that I did it. Okay, they're very cute, right? So HIV is like that, right? Kid. So okay, a naughty kid. So it is basically showing a uprise in infection, a upbeat in infection, and is showing a clinical latency, and then afterwards it will just progress up. Okay, and the patient will just up. Okay. So CD4 counts here they are the least, and CD4 counts start decreasing. Okay, we have a variety of symptoms at less than 50, less than 200, less than 50. Like this, we have a lot of symptoms. We'll see in the next sessions. Okay? So here, leukopenia occurs usually in this part. We have you can say normal, nearly normal CD4 counts, right? Viremia will occur resolution period of 2 weeks associated with level of viremia and increased number of TC cells. So after initial viremia, a viral set point occurs. Okay, a viral set point occurs. This viral set point, the viral set point, the amount of virus produced, the virus is replicating, right? The amount of virus produced, it tries to remain constant and remains constant for years altogether. So initially, we'll see some very mild symptoms. Whenever the patient of AIDS presents at the later stage. Why? Because very mild symptoms are seen in the initial phase, right? Macular rash just on your trunk and so means for how you can expect, right? So AIDS screening of AIDS is very important. We'll talk about screening as well. Okay, so after initial viremia, a viral set point after a viral set point occurs. A viral set point is basically causing the clinical latency, the latent period. Okay, whenever when the virus is replicating but constant rate. Okay, so infected person is basically producing 100 billion new virions per day. So your body has become the factory for the virus and it's happily progressing. So prognosis: a patient with more than 1,000 copies of viral RNA per ml of plasma is poor prognosis. But you just remember this lower limit of CD4 count is 500 cells per milliliter, right? Then we come to the middle stage. This middle stage is in untreated patients. It takes 7 to 11 years. This is basically 7 to 11 years. Middle stage means clinical latency. Viremia is very low. Production of virus goes on in lymph nodes. In lymph nodes, the whole khichdi is being cooked and your body is not acting here. So AIDS related complex, whenever we say that AIDS related complex, you can remember by FL, F square, L square basically. So F square is fever, fatigue, L square is lymphadenopathy and loss of weight. So unexplained loss of weight can be a sign of AIDS. Okay. Then comes the late stage. Late stage means a drastic reduction in CD4 counts. And there's a drastic reduction, the patient moves up, right? So there is an increase in opportunistic infections and malignancies. So what are the opportunistic infections that are associated with the AIDS, right? Okay, so let's talk about bacterial infections first. So bacterial infections, we can have infections by salmonella. Okay, salmonella, some kind of bacterial pneumonia like pneumocystis zerovesi pneumonia, right? Extrapulmonary TB and non-tubercular mycobacterial infections like Mycobacterium avium complex (MAC), right? Infection by this also. We can have fungal infections. I told you Girovicine, viral one. Sorry, it's a fungus, right? So fungal infections we can remember by PHC3. Okay, PHC3 means Pneumocystis carinii as well, and Pneumocystis jirovecii as well. Carinii is a rat species and jirovecii is a human species. Carinii doesn't cause infection in us, right? Jirovecii cause. So, if a patient is showing an X-ray where diffused infiltrates on the lungs, okay, and cough and pneumonia and all this, you can suspect a jirovecii infection, right? Histoplasma capsulatum, Candida, Cryptococcus neoformans, okay, and Coccidioides immitis. Okay, you must have heard about the Mickey Mouse sign or the Captain's Wheel sign. Okay, Paracoccidioides, and all many things are there, right? Microbiology. Just read. Viral infections like herpes virus infection. You can have infection by cytomegalovirus and chronic herpes simplex virus. Okay, then you can have CMV retinitis. In the CMV retinitis, the important feature is your Howl's eye appearance. Okay, you must have read in the pathology. Howl's eye appearance and CMV diarrhea. Okay, CMV also causes diarrhea, cytomegalovirus. And AIDS, diarrhea, and retinitis. PML is caused by JC virus. JC virus you must have heard. I'm definitely sure you must have heard. John Cunningham virus. Okay, so John Cunningham virus is basically Papova virus. It's a Papova virus. Okay, a type of polyoma virus. The only medically significant polyoma virus is JC virus, right? Can have parasitic infections like disseminated strongyloiditis. So strongyloides tuberculosis, you must have heard about this organism. Toxoplasma encephalitis. Toxoplasma is basically causing the encephalitis, right? Diarrhea by coccidian parasites and atypical disseminated leishmaniasis. Okay, leishmaniasis can also be caused. You can have cancers like Kaposi sarcoma. Kaposi sarcoma must have seen the it can be bullous or it can be just simple rashes. Purple to red appearance is there. And invasive cervical cancer can also be caused in primary CNS lymphoma. Okay, primary CNS lymphoma, which is a B cell origin. Must have heard this in pathology. Other conditions like HIV encephalopathy and symptomatic HIV associated with nephropathy or cardiomyopathy. Okay, so we talked about the basics of HIV. Okay, you must have read all the roots, right? I didn't talk much about this. You know that the HIV virus is primarily transmitted by sexual route, by the body exchange of body fluids, transmission by saliva. I'm telling few parts, you can just note it. So, sexual is the primary mode of transmission. The people who have multiple sexual partners tend to have a higher risk, and it is not transmitted by saliva. It can be transmitted, theoretically is possible, but very less chances by saliva kissing. Okay, very less chances of transmission. It is not significant, right? Okay. Then other modes, parenterally it can be transmitted to the baby, and by blood routes, the intravenous drug users and all these have a very high risk, correct? Know this one. Lab diagnosis. Let's come to lab diagnosis. So we can have screening tests and supplemental tests. After lab diagnosis, we'll move to the treatment aspects. Okay, and then we wind up the session. Okay. So screening tests and supplemental tests. So screening test is basically ELISA will take somewhat like 2 to 3 hours, but ELISA is a good one, good method, right? But less than 30 minutes. Some tests are there which will take less than 30 minutes, which are the rapid test, ICT. Okay, which have increased sensitivity. What are the antigens used? You can use your GP 24 and 41, okay, and GP 120 and 160. 160 is basically a combination of GP 120 and GP 41. So you can remember like this. It's a HIV 1 specific, present in HIV 1. Just remember HIV 2 specific one, GP 36. Okay, HIV 1 specific, HIV 2 specific is GP 36. Okay. Then let's come to the supplemental tests. Supplemental tests have increased specificity, right? These are costly, labor-intensive tests, okay, like Western blot. Western blot is a type of immunoblot technology which you have read in immunology part. So here it can you can detect antibodies to GAG gene, antibodies to Pol gene, antibodies to M gene. Okay, all the structural genes you have to detect antibody, the corresponding antibody to that structural gene in your blood, right? So antibodies to GAG gene you can remember by P40, 55, 40, 24, 18. 55, 40, 24, 18. Pol gene 55, 56. You can remember like 55, 65. Okay, and N gene, ENB gene, you know this GP 120, 160, GP 41. So GP 41 is basically splitting into 120 and 41. So just remember, you have to remember this two. So say with me, GAG gene we have GP 55, 40, 24, 80. 55, 40, 24, 80. And Pol gene we have 65, 55. Just remember this. 65, 66, 55, 51. Just remember this. Reactive results. So what result will say that this is a HIV infection? So according to WHO, we have another defined standard, and according to CDC, Central that CDC, okay, CDC standard. Okay. So WHO criteria is presence of at least two enveloped band. Presence of at least two out of 120, 160 or 41 with or without gag or Pol bands. With or without gag or Pol. Gag or Pol may be present, may not be present, but you must have either GP 120, GP 41, either GP 120, either GP 160, either GP 160, GP 41. Okay, you can have either of the two at least. And CDC says that you can have any two out of 24, 41, 120, 160. You can have any two out of this one, HIV one specific. Okay, any two. Done? Okay. So this was one of the methods. This supplemental test and screening test. Then we can detect the P24 antigen. P24 antigen. So it is detectable 12 to 26 days of infection, last for 2 to 3 weeks. Again, increase in the late stage. So it is basically showing a drop here, right? Sensitivity is less, and what are the uses? It is basically a confirmatory test. It confirms the diagnosis. Is having the diagnosis of the window period, latent stage in HIV in infants also. It is helping in the diagnosis of HIV in infants also, but it is not reliable. We'll see the reliable test in a few seconds. Monitoring progress of HIV infection and to resolve equivocal Western blot results, right? Viral RNA detection. You can detect the viral RNA. First of all, you did screening, then you did supplemental tests, some specific tests, right? Antibody to ENP, GAG, POL. Then you did your P24 antigen detection, P24 antigen detection, and afterwards you are doing viral RNA detection. So you can detect Pol and N gene. So viral RNA detection, remember, first of all, it's the gold standard, important, very important. The gold standard method, right? Most sensitive and specific method. You can detect Pol and N gene. Pol and N gene. Okay. You can detect by RT-PCR. You can detect by branched DNA assay, NASBA, real-time RT-PCR, right? All of this. The best tool to diagnose infection in the window period. The P24 was also helping in diagnosing the infection in the window period, and this is also helping, right? It is helping in the viral load monitoring. It is helping in the viral load monitoring, and it is helping in the typing and detection of drug-resistant cases as well. Okay. DNA PCR. DNA PCR is detecting the proviral DNA, and it's a very good to make the diagnosis of the pediatric HIV. It's very good in making diagnosis of the pediatric HIV, right? And window period too. You can do isolation culture, and this is not done. Okay, it is not done. It is obsolete, costly. It takes more than 6 weeks for the diagnosis. Okay, not sensitive as well. Two methods. You can either have direct method or co-cultivation. Okay, you will either take the your mononuclear cells out of this. Okay, from the bone marrow, and you can culture it. Okay, and co-cultivation means you can take the peripheral bone marrow cells, peripheral blood mononuclear cells. So I'm saying bone marrow. peripheral blood mononuclear cells from a heterologous HIV uninfected person, and you have to treat with that and treat with the viral infected cells, right? So you have to fuse the cells, and the fuse can be cultured along with the PBMs from the patient. Don't have to remember this much of detailing. So viral growth in culture is detected by PARSI. You can remember like this P24 antigen detection, RT. Okay, syncytium formation is a cytopathic effect. Cytopathic effect refers to the effects produced by the viral cells in response, the host cells in response to the viral infection, right? Or direct immunofluorescence. You can have non-specific tests like CD4 T cell count by flow cytometry, or you can detect abnormal proteins like neopterin, beta 2 microglobulin, soluble IL-2 receptors. Okay. Prognosis or monitoring, CD4 count is the most common monitoring marker. Okay, you can. It is very easy to measure the CD4 count, and you can best one is the viral RNA. Okay, viral RNA, the best method. You can see over here also. Viral RNA is the gold standard, right? So HIV DNA PCR is the most common detection for the most common method for diagnosis of pediatric HIV. Okay, many modalities are there for pediatric HIV, but HIV DNA PCR is the good option, right? And other methods we can have HIV RNA, P24, IgG ELISA, right? These all methods are also used for the pediatric HIV. Okay, so whenever you have a baby, do HIV DNA PCR at 6 weeks. If positive, then you can reconfirm by repeating the procedure. And if it is positive or negative, you can depend on the ART results. Afterwards, you can start. Next, we'll come to the pharmacological aspects. So, talking about the drugs of HIV, you can have ART, we tell it that ART or antiretroviral therapy, or you can have HAART. Okay, nowadays our approach to is moving towards a more holistic approach. So you can have highly effective retroviral therapy, right? And we follow the NACP guidelines. NACP guidelines is National AIDS Control Program guidelines. Our the government has made beautiful guidelines for the AIDS, right? You know all the structure. So this is a basic structure. We told we have three enzymes here, and this GP41 and 120 are attaching to the CD4 receptor, and this I told is the co-receptor. Co-receptor we have CXCR4, CCR5, CCR2. These three are the co-receptors. CXCR4 is present when you have the TH cells, and the CCR5 is present when we have the microphage or the monocyte cells, right? Okay. First one are the entry inhibitors. So let's look at the diagram first. Okay. This is the diagram. Okay, this is the diagram how HIV is infected. So first of all, the virus comes. So first we have to prevent the entry of the virus. Okay, for preventing the entry of the virus, we have entry inhibitors. The first class of drugs are the entry inhibitors, also known as the fusion inhibitors. Next, the virus attaches. Okay, the virus attaches. It indexes ssRNA. This ssRNA is converted to dsDNA. By which enzyme? Reverse transcriptase. So we have reverse transcriptase inhibitors or RT inhibitors. Okay, first is the entry inhibitors. Second is the RT inhibitors. This viral DNA is incorporated with the genome, okay, by the enzyme integrase. Next, we have integrase inhibitors. Okay, to prevent this. And this human DNA is producing viral proteins. These viral proteins are inactive. They have to be activated and produce the virions. Okay, if the viral proteins aren't activated, how will they produce the total virions, right? So these viral proteins, the assembly is basically done by protease enzyme, right? Protease. So we can inhibit the protease also. Protease inhibitors. Four classes of drugs: entry inhibitors, RT inhibitors, integrase inhibitors, and protease inhibitors. So read this. Sorry. Let's come to entry inhibitors. So you can remember the drug enfuvirtide. Okay, enfuvirtide. Enfuvirtide, you can just remember from the name itself. En is envelope, Fu is fusion, vertide. Okay, enfuvirtide is the GP41 inhibitor. What? Enfuvirtide is the GP41. Next, you can have fostemsavir. Fostemsavir. Okay, fostemsavir is the GP120 inhibitor. Understood? Next, we have a monoclonal antibody, ibalizumab. Ibalizumab is the CD4 receptor inhibitor. Okay, it is the only antibody for available for HIV. Okay, ibalizumab. Then we have CCR5. What is CCR5? Co-receptor. So we have Maraviroc and Bikriviroc. Okay, Mara means kill. Kill means HIV. We are basically preventing from the kill, right? So Maraviroc. So VI means a virus. R is the receptor, the co-receptor. Okay, COR is the co-receptor. ROC, COR is the co-receptor, right? So Maraviroc and Bikriviroc are basically inhibiting the co-receptor, CCR5. Then we have the Cenicriviroc. Cenicriviroc, how to remember? We have double C's, so it is a dual. We have dual means CCR5 also, and we can inhibit CCR2 also. V virus, ROC, co-receptor. Is it EN, envelope, or you can say entry, right? So all synonym. Shakespeare once told what synonym, but all are in a name, right? Then we have the Lencapavir. Lencapavir. So cap, what is that? So it's the capsid inhibitor, right? It is an injection, and these all are given in HIV 1. This three medications only in HIV 1, and these all HIV 2, and Lencapavir also injection is used in HIV 1 and 2. Okay, so what drugs we learned? Enfovirtide, which is the GP41 inhibitor. Fostemsavir, which is the GP120 inhibitor. Then we learned about ibalizumab. Ibalizumab is a monoclonal antibody. Ibalizumab is the CD4 receptor inhibitor. CD4 inhibitor. Okay. Then we discussed about the Maraviroc and Bikriviroc. Maraviroc and Bikriviroc are CCR5 inhibitor. Right. And then we talked about Cenicriviroc. Cenicriviroc was the dual, double C's. Okay. In CCR5 and CCR2. Right. And we have the Lencapavir. Lencapavir is the capsid inhibitor. So let's say after the virus has entered. Okay. So first line we will use reverse transcriptase, integrase, and protease because in many cases the virus has entered. This entry inhibitors are the second line drugs basically. Okay. So reverse transcriptase inhibitor. Reverse transcriptase is the RNA dependent DNA polymerase. Why? Because it is converting the RNA to the DNA, right? So it is RNA dependent. Okay. It is converting the RNA to DNA. So it will use the RNA template and convert it into DNA. So reverse transcriptase inhibitor may be of three types. We can have either NRTI. NRTI is the nucleoside reverse transcriptase inhibitor. Okay, nucleoside reverse transcriptase inhibitor means it is acting as a nucleotide. Nucleoside. Nucleoside, you know, right? Doesn't have phosphate, only sugar and nitrogenous base, right? It's acting as a nucleoside and competing with the reverse transcriptase enzyme. But can a nucleoside compete? It has to be phosphorylated. So NRTA, the nucleoside reverse transcriptase inhibitor, require phosphorylation and competitively inhibit the reverse transcriptase enzyme. Then we have the NTRTA. NTRTA is the nucleotide reverse transcriptase inhibitor. It doesn't require phosphorylation. It is a competitive inhibitor. Okay. Then we can have NNRTA. NNRTA is a non-nucleoside reverse transcriptase inhibitor. Non-nucleoside. It doesn't require phosphorylation. It's non-competitive. It's both N. No. Means no phosphorylation, no competition. Okay. Okay. We have to remember the examples as well. Pharma is all about drugs, right? You have to remember just whenever there is a, just a minute. Okay. Whenever there is a logic, I am telling you, and whenever there is not a logic, then you have to remember. Okay. Okay. I will make it easy. NRTI. NRTI. So first of all, you remember Woodin. All the Woodins. Stavudin. Okay. Lamivudin. Jidovudin. Stavudin. Lamivudin. Jidovudin. Okay. All the Woodins are NRTI. We can have two citabines. Citabines means not Mr. Beans. Okay. Two citabines. Jalcitabine, emcitabine. Okay. Jalcitabine, emcitabine. And two other drugs that you remember, lidinosine and abacavir. Okay, you have to remember this list. First, budins, three budins, two citabines, two miscellaneous. Three budins, two citabines, two miscellaneous. Stavudine, lamivudine, and your zidovudine, right? Then zidovudine was the first ART which was developed, right? And emtricitabine and jalcitabine and diadenosine and abacavir. Can you remember? Yes. Common side effects. Bone marrow suppression is one of the most common side effects, right? Maximum done by zidovudine. Okay. So it is contraindicated in anemia patients as well. Can have myopathy, can have pancreatitis. Maximum pancreatitis is done by diadenosine. Okay. And peripheral neuropathy, lactic acidosis, hepatic stenosis, all are basically maxed by stavudine. Okay. Stavudine. So these things you have to remember. And abacavir is the only NRTA which is used only in HIV-1. Okay. Rest all can be used in HIV-1 as well as in HIV-2. And abacavir has a special side effect or hypersensitivity in HLA 5701 predisposed individuals. Okay, you can see this HLA-B 5701. So you have to do HLA testing, and if this pattern of HLA is present in the individual, you don't have to give this because the patient will end up in severe hypersensitivity, right? And this jalcitabine has a side effect which I have missed here is the aphthous ulcers in the mouth. मुंह जल गया, I can remember this. Okay. Okay. Don't combine zidovudine and stavudine. Don't combine diadenosine and stavudine. Okay. And don't combine lamivudine and diadenosine. Okay. So diadenosine and stavudine are basically causing pancreatitis. Both are causing pancreatitis. So don't combine. Lamivudine and diadenosine have no specific benefits. And this zidovudine and stavudine are basically antagonists. Okay. Because this is a competitive, right? They will antagonize itself. With so synergism, zidovudine and tenofovir. Tenofovir, I told, I will tell that it is a NTRTI, that is a nucleotide reverse transcriptase inhibitor. So zidovudine and tenofovir you can combine. Lamivudine or emtricitabine you can combine. Okay, means you can combine zidovudine with emtricitabine. You can combine lamivudine with tenofovir. You can combine lamivudine with zidovudine. Okay, or vice versa. NTRTA is a tenofovir. Tenofovir is a special drug. We have to remember some points about this. Like it is a drug of choice for HIV as well as hepatitis B. Okay, it is a drug of choice in both of these conditions, HIV as well as hepatitis B. Right. Side effect is nephrotoxicity. It will cause Fanconi syndrome. It is contraindicated in children, renal failure in children. It is causing nephrotoxicity. Okay, Fanconi syndrome. So we can have two salts, tenofovir diproxil, okay, and tenofovir alphenamide. So common drugs for HIV and HPV. Okay, you can remember like TEL, TEL. T stands for tenofovir, E stands for emtricitabine, which is also used, and L stands for lamivudine, right? TEL. Then we'll remember NNRTA. NNRTA is only used in HIV-1, not used in HIV-2. So you have to find in MCQ exams, you have to find the VIR word, VIR in between, not in last, not in first. VIR. Okay. Nevirapine, ephiravenz, itravirine, doravirine, delaviridine, relpinavirine. Okay, to remember this. Need dire relief. This is mnemonic. You can remember like this also. Okay. So nevirapine, efavirenz and nevirapine are very good drugs. Okay, you have to remember. Etravirine, delaviridine, okay, and relpinavirine. Common side effect is SJ syndrome or rash. Okay. So just let's see nevirapine and efavirenz. Nevirapine and efavirenz in a different format because it's asked. So nevirapine is a CYP metabolized product, right? It is metabolized by CYP3A4. Efavirenz has no CYP metabolism. Some books write that it is metabolized by CYP 2C19. In your KDT, it is written. So it is metabolized by CYP3A4. So it will interact with some CYP inducers, mainly tubercular drugs, right? Rifampicin. Rifampicin is an anti-TB drug, right? It acts with rifampicin. It will basically reduce the effect. Rifampicin will reduce the effect of nevirapine, and so this will never combine. Okay, and nevirapine is hepatotoxic, and efavirenz is neurotoxic. Nevirapine hepatotoxic, efavirenz neurotoxic. You can remember like this: N will not cause N. Okay, but E will cause H. E will not cause H, N will not cause N. Okay, you can remember like this. Just a silly mnemonic means N for nevirapine, but it is not causing neurotoxic. Okay, it is not causing neurotoxicity. It's causing hepatotoxicity. Okay, let's talk about integrase inhibitors now. We talked about entry inhibitors. We talked about your RT. Reverse transcriptase inhibitors. Now we'll talk about the entry inhibitors. Integrase inhibitors. Integrase inhibitors, just remember, the drugs will end in gravir. Okay, gravir. With preventing DNA strand transfer to human DNA. You can have bictegravir, cabotegravir, dolutegravir, elvitegravir, raltegravir. Okay, raltegravir, dolutegravir must have heard. Okay, and these all are there. So bictegravir, cabotegravir, dolutegravir, elvitegravir, and raltegravir. Done. This cabotegravir is IM drug, rest all are oral. Pharmacokinetics metabolism is CYP3A4, so it will not be combined with rifampicin. Side effect is rashes. Just names are important. You can remember? Yes? Okay. Now let's talk about protease inhibitor. Protease inhibitor. These are inhibiting the assembly or the packaging of viral proteins, right? And this is important. So remember specific side effects as well. And then we'll discuss about the management and all, right? So integrase, what are the entry inhibitors? Let's revise. Entry inhibitors was which drugs? Enfuvetide, fostemsavir, maravir, Vicrevira. Okay. Then Lencapavir, Sanicrivira. Okay, all of this. And then we'll talk about NRTI. NRTI was the three budin, stavudin, lamivudin, zidovudin, and also two citabin, emtricitabin, zalcitabin, and two miscellaneous drugs like didenosine and abacavir. NTRTI only one drug, tenofovir. And we talked about NNRTI. Okay, and that you have to find the beer word. If we have okay, uh, that what are the drugs? Efiravent and nevirapine. Okay, all of this. Okay, you can see here. Nevirapine, efiravent, and itravirin. Okay, itravirin, doravirin, delavirin, remdesivir. Then we talked about integrase inhibitor. Integrase inhibitor find gravir, raltegravir, dolutegravir, bictegravir, cabotegravir. Okay. Next, we'll talk about protease inhibitor, that is Navir, NAVIR, Navir. Okay, so we have ritonavir, amprenavir, fosemprenavir, tipranavir. Okay, then we have indinavir, saquinavir, lopinavir, atazanavir, nelfinavir, darunavir. Many drugs to remember. I know, but you have to remember what can we do. Okay, okay. Just for entrance examination, just focus on remembering. You have to know this. This list you have to know, but whenever there is a special point about the drug, it is worth remembering, right? Like atazanavir. Atazanavir causes hyperbilirubinemia. Okay, it causes jaundice. So I will remember this obviously. Right? Okay. Ritonavir, emprenavir. Just stay with me. Ritonavir, emprenavir. Then we can have fosemprenavir. Fosemprenavir means emprenavir is phosphorylated, right? And it is made more oral. Phos. So fosemprenavir. Tipranavir. Okay. Then we have Indinavir, Indinavir, Saquinavir, Lopinavir. Lopinavir you must have heard. Atazanavir, Nelfinavir, Dabinavir. Okay. Common side effect is lipodystrophy syndrome. Okay. Lipodystrophy syndrome. Okay. Specific side effects. So renal stones is a side effect of Indinavir. Indinavir. Okay. We Indians have kidney problems, if I remember like this. Okay. Indianavir, renal stones. Then HH, hypertension and hemorrhagic shock are caused by tipranavir. So you have to remember Indianavir, you have to remember tipranavir. So hypertension and hemorrhagic shock is caused by tipranavir. I told you hyperbilirubinemia is caused by atazanavir. So atazanavir causes jaundice and kernicterus. And saquinavir, Q is there, right? So QT prolongation. So QT prolongation is caused by saquinavir. So pharmacokinetics, all are substrate of CYP3A4. Okay, so basically they will act with interact with rifampicin. So you don't have to give it rifampicin. Maximum CYP inhibitor is ritonavir. Okay, ritonavir will increase the toxicity of other drugs like warfarin and midazolam. Warfarin is used in the coagulation, right? Bleeding, and this will increase the toxicity, so there will be more bleeding, right? And midazolam will cause respiratory depression with this drug. So these drugs are contraindicated here, right? We have something called as a boosted protease inhibitor. Boosted protease inhibitor means the ritonavir is combined with in low doses. Okay, is combined with protease inhibitors. The ritonavir is combined with low dose ritonavir is combined with protease inhibitors. It will inhibit the CYP3A4 and it will boost the plasma levels of other protease inhibitors. So ritonavir in combination with other protease inhibitors is basically causing a boosted protease inhibitor. It is very good for you. And lopinavir, ritonavir can be given. Indinavir, ritonavir can be given. So we talked about all the drugs like ritonavir, emprenavir, fosemprenavir. So emprenavir, fosemprenavir you can skip. No special part. Ritonavir is maximum CYP inhibitor. You have to remember tipranavir is the HH, hemorrhagic shock and your hypertension, right? And Indinavir, I told you, Indinavir, India, renal stones, renal calculi. Saquinavir, Q is the QT prolongation means there will be a arrhythmia called as the torsidis depointis, right? And lopinavir and atazanavir. Lopinavir, you just remember that it can be combined with the ritonavir to form the you know, boosted protease inhibitor, right? And atazanavir, I told you, hyperbilirubinemia, that is the jaundice and kernicterus. Elfinavir you can skip, and darunavir you can skip also. Just not much important. Other miscellaneous drugs, we can have cobicistat. Cobicistat means C is there, right? C is there. CYP3A4 inhibitor. Okay, not much important. Cobicistat. We can use octreotide and crofelemer. You must have read in GIT chapters as well. These are basically used in the HIV-induced diarrhea. Okay. If time permits, I will take a session diarrhea also. So it is used in HIV induced diarrhea, right? This octreotide, crofelemer. You can use tesamorelin. Tesamorelin is a recombinant GHRH. Okay, recombinant growth hormone releasing hormone, tesamorelin. Okay, and this is used in the treatment of lipodystrophy syndrome in HIV patients. So lipodystrophy occurs in HIV, and you have to treat it with tesamorelin. Next, we come to the last part, that's the management of HIV. So we have to follow the NACP guidelines. Treat all the HIV patients irrespective of the CD4 count. If HIV is there, we talked about diagnostic criteria, right, in today's session, right? In the WHO and CDC criteria, that 2 bands must be present out of GP, that all the GPs like P24 and that GP 160, GP 120 or GP 41, right? And CDC says that CDC criteria is different from the WHO, right? No drug is contraindicated is in pregnancy. Okay, earlier if was said to be contraindicated, but now no drugs are contraindicated in pregnancy. Give at least 3 ARTs from at least 2 different groups. So you have to give 3 ARTs from 2 different groups. Remember this. Give us FDC. So nowadays fixed dose combinations for HIV are available. So in India, the drug of choice now, it's the update. Many teachers are even wrong here that the drug of choice is TLD regimen. TLD regimen, not TLE regimen. Okay, many teachers say that it is a TLD regimen, but it is incorrect. Nowadays, it is the TLD regimen. TLD stands for tenofovir lamivudine diadenone. dolutegravir, not dydrogesterone, dolutegravir. Tenofovir, lamivudine, and dolutegravir. Tenofovir is NTRTI. Lamivudine, Woodin was the NRTI, right? And dolutegravir, okay, gravir was the integrase inhibitor. Remember this all, right? Raltegravir, dolutegravir, victoregravir. If TLD is not an option, you can go with TLLR or TEL. TLLR is the tenofovir, lamivudine, lopinavir, ritonavir. TEL is the tenofovir, efiravir, and lamivudine. HIV in pregnancy, you will use the same TLD and or you can use TEL or TLLR. HIV in children. In children, adult and age. Okay, if it is the patient is adult and age is less than 10 years, okay, the weight is less than 30 years, then the TLD regimen will go as it is. If the age is 6 to 10 years, okay, this is a child, 6 to 10 years age, weight 20 to 30 kg. So you'll have ZLD regimen. You have ZLD. Here TLD is changed to ZLD, means Judobudin will be replaced. Judobudin will be there. If the age is less than 6 years, okay, and weight is less than 20, use ZLLR regimen. ZLLR. TLLR regimen was there. You have to use your ZLLR, means Jidovudin and Lamivudin, Lopinavir, Ritonavir. Right? Renal failure, avoid tenofovir. Okay, you don't have to give this T. Give Jidovudin or Abacavir. Okay, means you have to use here in a renal failure adult patient. Will you use TLD regimen? No, you will use ZLD regimen, right? Okay, if HIV is less than 9, so what will you use? Bone marrow suppression was the side effect of which Woodins, right? Woodins. So Jidovudin will be contraindicated here. Don't have to give Jidovudin. Okay, so you can't give ZLD regimen. You have to give TLD regimen. So Ramibudin is also contraindicated. You can um, try giving all the. Okay. Prophylaxis in newborn infants. So if a child, if an infant is born to the HIV positive mother, then you have to take the prophylactic measures. Okay. So HIV is excreted in breast milk. So there will be a parental transmission, a parent to child transmission, right? So breastfeeding should be continued in India. Okay. Breastfeeding because the child is receiving the antibodies as well. Virus is passed in very low amounts, but in America basically the breastfeeding is basically contraindicated. We have to do artificial feeding. But in India, where the majority of the population is in below poverty line, right? What can we do if we discontinue the breastfeeding, right? The child will die out of loss of this. The immunity will be decreased at further. Okay, even further. So low risk infant means maternal HIV after 32 weeks. The HIV number of HIV virus after 32 weeks is less than 1,000 copies. If it is more than 1,000, they're high risk infant. Less than 1,000, high low risk. So low risk infant must be given nevirapine syrup till 6 weeks. Okay, low risk infant till 32 weeks, less than 1,000, nevirapine syrup till 6 weeks. High risk infant must be given nevirapine syrup plus Jidovudin till 6 years. Post exposure prophylaxis. If there is an accidental needle stick injury, let's say you were carrying out a procedure or doing something, a surgery or something, and you suffer a needle stick injury, or you pricked your finger with the suture needle, or whatever happened. Okay, so within less than 2 hours, you have to start the post-exposure prophylaxis as well, because you don't want to have HIV. Yeah. So you have to give 3 ART drugs. PEP, the post-exposure prophylaxis PEP is given for 28 days, 1 month. Okay, this is the duration. So you have to start less than 2 years, right? You have to give 3 ART drugs, and you have to give the exposure prophylaxis for 28 days, right? So age less more than 10 years and weight more than 30 kg per adult, then you have to give the TLD regimen as usual. If the age is 6 to 10 or weight is 20 to 30, you have to give ZLD regimen. And if the age is less than 6 and weight is less than 20, you have to give ZLLR. Okay. So that was about HIV, and I know you have to have prevention. You can use during sexual intercourse. You have to refrain from reusing the needles. You have to refrain from multiple sexual partners. You have to know your partner well before having any kind of fluid exchange between the bodies. You have to avoid unprotected intercourse with unknown people, right? Even if you are indulging it, then you have to use various contraceptive measures as well. For condoms and female femitoms are available, and diaphragmatic caps have a wide list of contraceptive measures which are available. You can use this, and just be safe, and don't be, you are a doctor, right? So don't fall prey to this things. Needle stick injuries must be avoided at any cost. Right? These are very hard measures, and this cause a source of stress for the doctors as well. Right? So that's all in today's session. I hope you enjoyed the session, and I enjoyed teaching the topic as well. Let's meet again in any other session and with a very fresh topic. That's all for now. That's all from me. Thank you and good night.